Hello, guys. I hope you are all okay and you're all enjoying your life. And welcome back to Dr. Arshad Nadeem Awan ultrasound and radiology teaching video. Today, I'm going to discuss about the gastric cancer, or generally it is also known as stomach cancer. This is basically the third commonest malignancy after the colon and pancreatic cancer. It is the cancer which is arising from the epithelium of the stomach or gastric mucosa, and it is called as adenocarcinoma. It is associated with multiple other factors, like it has link with its pernicious anemia, smoking, and multiple more. I will explain this in this video. Beside this, if you concentrate on patient's clinical history, patient might complain of vague abdominal pain. There will be nausea, vomiting if the cancer is in early stage. If the cancer is progress, so it may leads to obstruction and some other obstructive symptoms as well. As far as its types are concerned, it's depend on which modality you are using. Like there may be fluoroscopy, there may be ultrasound, but the role of the ultrasound is very minimal. You can diagnose this on the basis of histopathology, but CT scan is the one which is the best modality. Not the best, but to some extent it will help you to look for to what extent this cancer has been spread. How it will appear on the CT images, I have selected one of the beautiful CT scan. On that CT scan, I will show you how it will look like, how it will involve the surrounding areas, how you will be able to look for the bone metastatic on that particular visualized area of field, and then how you will be able to pick the pulmonary metastatic. All these are included in this video. Beside this, there are some other findings, like on the body there will be certain nodules, like Sister Mary Joseph nodules, which is around the umbilical area, or there may be appearance of the varicose nodule, which is especially in the supraclavicular lymph node. Krukenberg tumor or Krukenberg nodule, like if this metastasis involves the ovary, and there is another is Irish nodule, which all be included in this video, and I will explain step by step, and I'm sure this will benefit you. So let's start watching this video. Contrast enhanced CT abdomen and chest for the gastric carcinoma with pulmonary metastasis. Here on this image, I'm starting from the chest, and if you observe, I'm going down along the trachea, and you will see there in the cervical esophagus there is air fluid level, and if we goes down, so you will see that the esophagus is enlarged with circumferential heterogeneous mural thickening along entire thoracic esophagus, and it's coming downward to the gastroesophageal junction. Here at gastroesophageal junction, you can see heterogeneous extension of the soft tissue lesion extending into the stomach and involving the anterior and posterior wall. So this is what the extension of the tumor, and you have seen that all the way upward it's involving the esophagus, and it goes down and entering into the gastric mucosa. Beside this, if you focus on the stomach, you will see that there is a circumferential thickening of the stomach wall. However, distensibility is reduced, so we will put that patient this shows a lanatus plastica configuration. So this is how it will look. If you go down, and you can appreciate that along the greater curvature, here if you go, so along the greater curvature and along the body of the pancreas, there is fat stranding, and there is perigastric inflammatory stranding also seen. Few lymph node can be seen there, and however the liver, so for the liver is concerned, there is no hepatic metastasis. You can see that the gallbladder is distended. As far as the L2, L3 and L4 is concerned, there you can see the vacuum phenomena, and there is extensive degenerative changes. If we go slightly upward, so focus on the lungs window now, so you will see there are multiple ground glass nodules along the periphyseal and peribronchial and in diffuse distribution. Beside this, you will be able to see in the, here we go, in the left apical segment, apico-posterior segment, there is another nodule which is likely metastasis. So this is pulmonary metastasis secondary to the gastric carcinoma, which is extending all the way from the esophagus into the stomach, involving gastroesophageal junction and giving the stomach appearance of configuration of linitis plastica without any metastatic deposit. If you look for the stomach or anterior abdominal wall, it gives an scaphoid abdomen, scaphoid presentation. So this is what the gastric carcinoma with pulmonary metastasis. Gastric adenocarcinoma is a primary malignancy rising from the gastric epithelium, and it is the most common gastric malignancy, and it is the third most common gastric malignancy following colon cancer and pancreatic cancer. Gastric adenocarcinoma is quite rare before the age of 40, but after the age of 50 or 70, there is likely chance of developing gastric adenocarcinoma. There are multiple risk factors associated with the gastric adenocarcinoma. On the top is pernicious anemia. Adenomatous gastric polyps are also prone to develop the gastric adenocarcinoma. Atrophic gastritis. If the patient been through Billroth 2 partial gastrectomy, so he must be monitored for the development of the gastric adenocarcinoma. Type A blood group peoples are prone to the gastric adenocarcinoma, and smoking is one of the major risk factor for the development of the gastric adenocarcinoma. Gastric adenocarcinoma presents with dyspepsia and dysphagia. If it is large enough, it may obstruct the normal flow of the food to the stomach, so it may cause the solid dysphagia as well. There will be dyspepsia, patient will be having nausea and vomiting. There will also be early satiety. Patient might be having anorexic, or there will be a weight loss because of the fear of eating, which will eventually cause the pain. Luminal obstruction in case when the tumor is large enough to obstruct the gastroesophageal junction and the stomach upper part, which you have already seen in this patient, and as a result the patient had the scaphoid abdomen and mostly the weight was lost. So these are the clinical presentations for the gastric adenocarcinoma. If the gastric adenoma progress and it start developing metastatic deposits, so there are certain lymph node which has given its own particular nomenclature, like the Sister Mary Joseph nodes, when the umbilical or para-umbilical nodes involved with the malignant deposition, so this would be called as Sister Mary's Joseph nodes. Varicose nodes is very common. If the left supraclavicle nodes is enlarged, especially due to the gastric adenocarcinoma, this would be called as varicose nodes. Krukenberg nodes is actually these are not the nodes, but when the metastatic deposits involve the ovaries in female, this would be called as Krukenberg's node. Irish nodes are the nodes if the axillary lymph nodes are involved and the the malignant deposits involve the axillary lymph node. This would be called as Irish node. It depends upon patient to patient, but eventually if the case progressed, so you will see all these lymph nodes will be involved, and you will see these terminologies on the CT reporting. On fluoroscopic examination, the gastric adenocarcinoma presentation will be three types. Type 1 would be elevated lesion, and if it protrudes more than 5 mm into the lumen, and that would be considered as polypoidal lesion. The type 2 lesion would be a superficial lesion. This would be mostly plaque-like or mucosal nodularity, and there will be mucosal ulceration. In type 3, the lesion would be shallow with irregular ulcer crater with adjacent nodular mucosa. Sometimes there will be clubbing, there will be fusion, there may be amputation of the radiation folds. While in advanced case on fluoroscopy, the lesion would appear either polypoidal cancer, and this would be lobulated or fungating in characteristic. Lesion may be on a dependent part or posterior wall. It will be having a filling defect, like there will be a barium pooling in that. But if the lesion is on non-dependent, like the lesion is on the anterior wall, so it will shows the barium would be trapped between the lesion and the adjacent area or adjacent structure. In advanced case, there might be ulcerated carcinoma, which is actually penetrating carcinoma, and that is 70% of all gastric cancer can be seen. CT modality is also used to evaluate the features of the gastric adenocarcinoma. It will demonstrate a polypoidal mass with or without ulceration. It may appear as a focal wall thickening with mucosal irregularity or focal infiltration of the wall. It may appear as an ulcer, but that would be gas-filled ulcer crater within the mass, or it may be an infiltrating carcinoma with wall thickening or loss of normal rugal fold patterns. So I'm sure you would have enjoyed this video, and this especially gastric carcinoma clip which you have observed on the CT images. Beside this, I have explained all the typology and sign and symptoms and which modality is the best to use to detect the gastric carcinoma. So for other videos, just keep watching, stay in touch, and we will appreciate that if you just give me or send me some of your feedbacks, and even if you are not agree with some of the point, you still may write to me. So with some other images, with some other videos, we'll see each other. Till then, take great care of yourself. Bye bye.